good morning to you all, and we hope this day is going to be very fruitful for all of us. So let me start off by saying that our objectives for our talk today. So we will be discussing on portal hypertension in children to begin with, which is the commonest, I would say, the complication where you would see in children with chronic liver disease. So outline within the next hour or so, we are going to discuss about some of the anatomy of the portal circulation, definition, classification, diagnostics, as well as the management. So in the management, we would be discussing basically how to manage an acute problem as well as the long-term management. Okay, so let's just go to our medical school days just to recap what we have learned. So as you all can remember, so the liver is one of the largest organs we have, and which receives 1/3 of the cardiac output, which is 25%. And liver has two main blood supply from the hepatic artery as well as from the portal vein, where the portal vein carries 75% of the blood. As you can see here in this diagram, the portal vein comprise of two main kind of veins, so coming from the splenic vein as well as from the superior mesenteric vein. So the splenic vein get combined with the inferior mesenteric vein, which is kind of draining from the rectum as well as the left side of the colon. And then it comes to it in the medial 1/3 of the splenic vein, it attached to the splenic vein, and then it combines with the superior mesenteric vein, which drains from the right colon, small intestine, as well as the head of the pancreas. And then it forms this portal vein, which is considered as one of the largest veins. And then immediately before it enters to the liver, it divides into two main branches, left and the right vein. And as you can see clearly in this diagram, later they kind of divide into small venules and then making the capillaries and sinusoids, and later they drain into the inferior vena cava via two hepatic veins. So portal system has its marked kind of pathognomic feature is it has a very distinct character. One of the distinct characters is it has a very low pressure. As you can see, the normal pressure which would maintain within the portal circulation is around 7 to 10 mercury millimeters. And this venous flow basically driven by the hepatic venous pressure gradient, which usually in between 1 to 4 mercury millimeters. So what happens in portal hypertension? So that is our normal anatomy, normal physiology in the portal circulation. But when your portal pressures increases more than 10 mercury millimeters, or if your hepatic venous pressure gradient is greater than 4 millimeters, then that instance, we call it as portal hypertension. So this is the definition. So these numbers can be vary. Some may consider it as about 12 mercury millimeters, and some the venous pressure gradient can take as 5 to 7. But basically, these numbers came from adult data, so we don't have any specific data for pediatric population. Having said that, we'll look at the classification. Basically, portal hypertension can be classified into two main arms. One is extrahepatic and the other one is intrahepatic. As the name implies, you can see one is due to the problems inside the liver, other is outside the liver. So the extrahepatic causes basically depend on the level of site of resistance to the portal flow. It could be prehepatic or it could be posthepatic. Whereas the intrahepatic portal hypertension, there are two main classifications in the literature. So one depends on the site of the obstruction, the sinusoidal level. So it could be in the pre-sinusoidal level, like portal venule, could be in the sinusoid, like in cirrhosis, where you will see the fibrosis or the nodules or any dynamic changes can cause pressure inside the liver, which is co-sinusoidal, and could be post-sinusoidal as well, which is the terminal part or the central vein. The other classification they say is, again, in the intrahepatic portal hypertension, it's not purely due to cirrhosis. So there can be other causes, non-cirrhotic causes, which again can cause portal hypertension, which we are going to discuss later. So that's the main classification we have at the moment. So let's talk about each component separately from now onwards. Okay. So what is prehepatic portal hypertension? This is, I would say, most of our children would come under this category, a part of the majority of chronic liver disease patients we have. So out of the prehepatic portal hypertension causes, I would say portal vein thrombosis is the main cause. So that is considered as the commonest cause for extrahepatic portal vein obstruction. Apart from that, you will see thrombosis in the splenic vein, or there can be congenital problems, anatomical problems in the portal vein as well, like could be atresia, could be agenesis, and could be stenosis. Apart from that, there can be abnormal connection between the arteries and venous system, so creating arteriovenous fistula. And very, very rarely, there can be extrinsic compressions of the portal vein, which can lead to prehepatic portal hypertension. Basically, you know, the hypertension is due to the resistance to its flow. So any cause which can cause increased resistance can lead to portal hypertension. When we talk about the hepatic causes, as I said before, so we can divide into three main groups according to the sinusoidal distribution, anatomical distribution. So, and some of the causes can be overlap in between, because cirrhosis, the reason for portal hypertension could be pre-sinusoidal, sinusoidal, or can be due to post-sinusoidal. So there can be, overlaps in between the causes. But basically, this is what we have kind of found out as causes. When we talk about pre-sinusoidal, basically the hepatic venule, so there can be causes like hepatic fibrosis, there can be neoplastic infiltrations, or chronic hepatitis can cause hypertension in the pre-sinusoid, causing hepatic portal hypertension. Or there can be sinusoidal issues like Wilson's, all the causes of cirrhosis in children, acute hepatitis, cystic fibrosis. It can change the sinusoid. It could be a mechanical change, like I said before, could be due to nodules, could be due to fibrosis, or it can be due to dynamic changes, like the change in the nitrous oxide and other cytokines which produce from the liver can change the dynamicity of the portal flow, causing hypertension. And the last part would be post-sinusoidal, where it overlaps with the post-hepatic causes as well. So we can consider veno-occlusive disease as one of the causes, where we do see this condition in children who has received chemotherapy or after bone marrow transplant, or there can be graft versus host disease, or due to radiation, we might see this portal hypertension due to post-sinusoidal causes. So this is a diagrammatic illustration of the sinusoid I was talking. So this is the pre-sinusoidal region where your portal vein starts and your sinusoids going into your central vein. So this pathology, the mechanism can happen anywhere in the sinusoid, leading to portal hypertension, which I would say very complex pathogenesis. So sometimes that's why we can't exactly say, so this is the only cause for causing portal hypertension in some of the diseases, because it's very wide and complex. Having said that, the second classification we discussed was the cirrhotic causes again versus non-cirrhotic causes causing portal hypertension in the liver, hepatic portal hypertension. As you can see in this diagram, so in the liver, so we have our blood flow, And as you can see, inside the sinusoids, there can be thousands of channels and interconnections. So if you look at the picture depicted in below, so you can see in the cirrhotic liver, what has happened to these sinusoidal channels. So most of the channels disrupted, and as a result, so the sinusoidal resistance has gone up. Whereas in non-cirrhotic liver, the pathogenesis, it's not that. So they will still have the intersinusoidal channels. However, there can be resistance into the blood flow in several other places, which lead into portal hypertension. So basically, this is a very simple diagram of just to explain what is happening inside the liver. So when we talk about non-cirrhotic portal hypertension, I thought it's better to discuss a bit about this condition, which is quite new, and we don't see much literature or evidence in the pediatric population, which is called obliterative portal venopathy or idiopathic non-cirrhotic portal hypertension. So the main feature is there is portal hypertension, but you don't see a cause, like there's no liver fibrosis or cirrhosis, and there's no vascular obstruction as well. But these children have evidence of portal hypertension. So they have looked for the possible etiology. Still, it's undefined, but there are so many theories behind, like there can be autoimmune causes, or there can be endotoxin-mediated injuries or vascular abnormalities are considered as the possible etiology for this condition. And when you do the histology, because of course, when you can't find a reason for portal hypertension, we end up doing liver biopsy. So even in the liver biopsy, you will see very non-specific changes like fibroelastosclerosis. There can be some fibrosis around the periportal or perisinusoidal areas without disruption into the lobular architecture. So this is one of the kind of entities which we need to know when we don't see a reason, when there is no vascular obstruction, or when there is no liver fibrosis or cirrhosis to cause hepatic portal hypertension. So these are some of the causes, postulated theories behind this non-cirrhotic portal hypertension as we discussed. There can be infective causes, there can be medications or toxins, and in some children, there can be some genetic predisposition, pro-thrombotic events, as well as immunological disorders. None is kind of conclusive, but these are some of the theories which they have put forward. Then we are coming for the third category out of the causes of portal hypertension, which is the post-hepatic portal hypertension. So as the name implies, there has to be a resistance to blood flow or sort of obstruction of blood flow from the liver into the IVC. It could be in the hepatic vein, it could be in the IVC, inferior vena cava, or it could be in the right atrium or the right side of the heart. So some of the common examples would be Budd-Chiari syndrome, could be inferior vena caval obstruction, could be problems in the heart like constrictive pericarditis or tricuspid regurgitations, right heart failure, and sometimes as a result of complex heart surgeries like Fontan procedures, then you might see this post-hepatic portal hypertension. So the most important fact in post-hepatic portal hypertension is, unlike pre-hepatic, sometimes you would see liver dysfunction because of the long-standing blood stagnation and back pressure can compromise your liver functions, and very rarely they can cause cirrhosis as well. So unlike in pre-hepatic portal hypertension, but post-hepatic portal hypertension in longer run can cause compromisation in the liver functions leading to cirrhosis. Having said that, this is sort of a diagrammatic representation of what I have discussed so far. So everything in nutshell, we have in this diagram, you can see the main locations of lesions, intrahepatic, prehepatic, or posthepatic, and the diagnostic groups and the few examples. Then let's see how these children will present clinical manifestations of portal hypertension. So that the things we have discussed happen inside the body, but we don't know. But with the clinical manifestations, we would know, okay, is this the presentation of portal hypertension? So let's look at those. So as you can see, the commonest and the most scariest presentation would be variceal bleeding. So as you can see in the diagram, what happens when there is an obstruction, it could be a resistance to portal flow. So inadvertently, what happens is this blood will go and it form collaterals to kind of, they find other means, other pathways for the blood to flow. So as you can see in this diagram, so there can be dilated vessels in the lower part of the esophagus, could be in the stomach fundus. Sometimes it could be in your umbilical vein, causing the the dilatation of the umbilical vessels, causing caput medusae. Sometimes it can be in the rectum, and if the child is having a stoma, so you will see this dilatation among the stoma as well. So this back pressure at one point will rupture because of the pressure they have and the blood flow, presenting as variceal bleeding. So if it is upper gastrointestinal bleeding, if it is above the upper part, first part of the duodenum, then they can present with hematemesis. So out of the hematemesis, I would say majority, 90 to 95% is due to esophageal varices, and gastric varices also contributes around 1/3, 35 to 40%. When it is below, when it is in the lower down, it can present as tarry color or melena, could be fresh bleeding as well if it is the rupture of the varix in the rectum. So they can present as melena. So that is one of the commonest presentations of portal hypertension. So as you can see here in this picture, so it could be hematemesis, could be melena. So as clinicians, it's very important to look at that, because sometimes mothers will say, okay, it's dark color, but actually it's not dark. So it's very important at least to get a photograph, or if you can see it, I mean, if you can evidence the color, so that would be really important before you kind of plan your management. So out of all, this would be the most common presentation in both hepatic and extrahepatic portal hypertension. So irrespective of the liver pathology, so even without a liver pathology like prehepatic, so this could be the most common presentation in children. Apart from that, they can present with splenomegaly. Sometimes splenomegaly is enlarged into the extent with hyperactivity. So then you would see hypersplenism causing cytopenia. So most of the time, they will be, mount to so many investigations. They might undergo bone marrow, thinking of a possible malignancy because of this persistent cytopenia due to hypersplenism. That would be one entity, or it could be completely undetected, or during a routine physical examination. Child can present with fever, or then you might detect this spleen. And then when you investigate further, you will find out this portal hypertension. So that is one of the other presentations of portal hypertension. Apart from that, children can have ascites, but I would say usually you will see ascites in patients with cirrhosis, but there can be other causes, other non-cirrhotic causes also will lead to ascites in children. And in that case, it's very important for us to get the ascites albumin gradient, which we call as serum ascites albumin gradient, because depending on the number, we can decide, okay, whether this is due to portal hypertension or due to something else, like there can be problems in the mesothelium, endothelium, or there can be problems in there can be infective causes, inflammatory causes for sinusitis. So when the number is above 1.1 grams per deciliter, that indicates portal hypertension. Because if you can remember your physiology, when your oncotic pressures, when your portal pressures are increased, so it pushes your albumins as well as fluids into the space, which increasing the serum ascites albumin gradient. Apart from that, they can present with cutaneous vascular spiders. So as I mentioned you before, when there is a back pressure, when there is increased flow, your blood flow will direct to other means. So cutaneous vascular spiders is one of the presentations in children. And growth failure, not only in cirrhotic causes, in prehepatic portal hypertension also children can present with growth failure. So when you the possible postulated mechanisms are, some of the mechanisms are because some of the growth factors, it get bypassed by the liver, so then it can cause growth failure in children. Apart from that, some of the rare complications I would say you would see in children with cirrhosis are the pulmonary complications. When you develop photosystemic shunts inside the lungs, causing perfusion ventilation mismatch. So it could be hepatopulmonary syndrome when we are having shunting, or it could be portopulmonary hypertension where there's increased pressure. Or there can be hepatorenal syndrome, or very rarely, they can even present with hepatic encephalopathy as well. So there's wide variety of presentations, but I would say out of all, the variceal bleeding and splenomegaly are the most common presentations in children. So once we suspect with the clinical features, once we suspect whether there is portal hypertension, so let's look at how we do the diagnostic workup. So when we discuss about the diagnostic workup, so as you can see, I have put a list starting from basics, from taking histories, physical examination, doing laboratory investigations, and then ultrasonography, imaging like CT, MRI, as well as fibroscan, endoscopy, and then actual measuring of the pressures. You can see the accuracy. So when you go down, so the most accurate would be to check the pressures, but which is very invasive due to anatomical differences, due to small sizes in the vessels. It's not practical and could be dangerous in children. However, when you discuss about the tolerability and feasibility, so it's the other way around. When you go with your history, physical examination, and the lab test and ultrasonography has good yield when you think about tolerability and feasibility. So let's talk about one by one. So when we talk about history, we all know, so there are certain questions you need to ask to check whether it's due to hepatic or extrahepatic. So out of the extrahepatic, we told you that the portal vein thrombosis is the commonest. So getting a neonatal history, asking about the history of umbilical vein catheterization, having interventions like exchange transfusions, history of any sepsis, any omphalitis, dehydration, prematurity. You should ask, but that doesn't say it's not always you would see, because 50% of the time you might not see any underlying reason. But in the history, you should need to ask this aspect as well. There can be other very rare conditions like myeloproliferative disorders, could be surgeries, there can be splenectomies, liver transplantations, there can be polycythemic conditions, which can lead to thrombosis, which you have to question in the history. When we look for physical signs, so it's your general examination and the specific abdominal examination. So you need to look for certain things like the size of the liver and the consistency is very important. And you need to see the size of the spleen, as well as the, we talked about the abdominal venous patterning. So you need to look at the site and direction. There can be spider nevi or telangiectasias, you will see. There can be other features like palm erythema, ascites, ankle edema. So these could be manifestations of the vasodilatation and splanchnic vasodilatation and increase cardiac output. So when we talk about the other diagnostic tests, so you're entitled to check a full blood count to see cytopenias, which you would see if there is hypersplenism. Of course, the liver function panel, because you need to see whether this is due to a hepatic or extrahepatic reason. And the next most important investigation in our part of the world would be ultrasound scan, abdomen, and Doppler, because compared to the other tests which we have discussed, this has a sensitivity and specificity about 95%. So most of the time, if we can ask for ultrasound scan, abdomen, and Doppler, you can gather a lot of information. Like you can look at the liver parenchyma, you can look at the size of the spleen, ascites, and patency of your portal vein, and the patency of your hepatic vein with their flow pattern, and if there is any thing like cavernoma formation or any portosystemic shunts. So I would suggest, so if we suspect portal hypertension, so doing an ultrasound scan, abdomen, and a Doppler can give you a lot of information with regard to the underlying etiology. Apart from that, we can discuss about CT and MRI. So if you want to assess the extent of the thrombosis, if you are suspecting a portal vein thrombosis, or if you are suspecting a complication like portal hypertensive biliopathy, or if you are planning for a surgery, before that we can do imaging, and of course liver biopsy if you have any suspicion of underlying liver disease to assess the fibrosis and cirrhotic changes. And last, you can measure the portal venous pressures. So there can be certain degrees of pressures which you can check. And by doing this, you can actually diagnose whether this is prehepatic, intrahepatic, and posthepatic. But as we discussed before, it is invasive, and sometimes the doing this would not give you an additional, information, because sometimes you can get all the information simply by doing the previous test which we have discussed. So here we are coming to the, I would say, the crust of this lecture, that would be the management of portal hypertension in children. So I would like to invite Professor Shaman Rajendra. So sir will discuss about the management of portal hypertension.
Good morning, everybody. So we are going to discuss about management of portal hypertension. Actually, I would like to thank Vatsala for making my life easier, giving a very good idea about the pathophysiology and what happened and going on. So what I would say, so we'll discuss about the part of the emergency management and part of the long-term management, and I will hand over the this to Vatsala again to finish the latter part of the lecture. So the treatment options for emergency management. Before that, what we need to think principally is this is probably one of the commonest gastrointestinal emergency apart from severe dehydration due to acute gastroenteritis. This is very dangerous as well as very, uh, and we feel afraid when you see blood in a vomiting blood. So you really need to think of what we are going to do. And unless your head is pre-programmed and planned, can do some error and you can have troubles in the law. So there are only three things that we need to think on emergency management, that is endoscopy, pharmacotherapy, and surgery. Let's see what we can do. First of all, a careful assessment and sensible approach are the two most important steps in this management. We can do a lot of things, but be sensible and we have a very good assessment of what is happening, because there are things that there are do's and don't do's in the management of variceal bleeding in children. So I know you can't see this. And this is the management plan for basically portal hypertension, which Vatsala, myself, and Meran created a few days ago. So the first part, we'll take that part first. And here we go. We'll have our upper gastrointestinal bleed. First thing is to, as approach to any medical emergency, you assess the airway and breathing, right? So sometimes when you vomit, you can have blood clots in the upper airway. So you need to clear that actually, something out of the secretions and blood and clear the airway at the beginning. Remove all the blood and blood clots. Sometimes they come from inside the laryngopharynx where the breathing is very difficult, and if necessary, the GCS low, you are supposed to intubate actually as well. So then you give 100% oxygen. You provide 6 to 8 liters would be enough, and go up to 10-15 liters per minute to make sure that the child is well oxygenated. Because it's losing blood. Don't do this, you develop tissue hypoxia, and at the end of the day, you will end up in acidosis, and we need to correct that time lapse. So then they assess the circulation by using the simple parameters like pulse rate, pulse volume, blood pressure, and capillary time. And after that, you know exactly where you are standing, whether your patient is hemodynamically stable or hemodynamically unstable with you. So at the initial cannulation, when you're assessing the circulation and cannulating the child, just do full blood count, random blood sugar, coagulation parameters, including ROTEM, and liver profile, electrolyte and creatinine, blood group and phosphatine, and venous blood gas. So then we go into management of somebody who is not having much of a shock. So if the fellow is hemodynamically stable, you can use the drugs that we use to control the bleeding, to constrict the splanchnic circulation and immediately stop bleeding as much as possible. So things available, most of the hospital, most of the teaching hospital, you can find octreotide. You can give octreotide bolus and an infusion, or you can use intravenous terlipressin as well as a bolus or as an infusion. So in addition, you need to start patients of acute hematopoiesis on intravenous proton pump inhibitors, as well as if you are having chronic liver disease, better to start intravenous broad spectrum antibiotic for infections, and then you keep on monitoring vitals. So after you start these things, you reassess the patient again and try to see where the patient is standing with regards to airway, breathing, and circulation. And if the patient is stable, plan for endoscopic variceal ligation within the next 24 hours. If they are unstable, then you go to the other side of the management. So the pharmacological interventions are, as I said, octreotide, initially used as a bolus 1 to 2 mics per kilogram, and then followed by an infusion, maximum for 5 days. Don't have to go for 5 days, most of the time within 48 hours, and get it controlled, right? So gradually stop after you just don't abrupt off, cut down 50% during next 12 hours, and then gradually the next 50% during next 12 hours. you can stop it. Terlipressin is a very good drug which has shown to be very effective during trials in adults, which has shown to reduce mortality very clearly. So you can use 20 microgram kg bolus every 46 hourly and infusion of 10 mics per kg per hour. So as I said, PPI, you can use omeprazole bolus and infusion and antibiotic broad spectrum antibiotics. So then we go to this section where the patient is not hemodynamically stable and having shock. So if you detect shock, and that means if you think the peripheral organ dysfunction is there due to inadequate circulation, then you need to resuscitate the patient, which normal saline bolus, 20 kg bolus, rapid boluses. You can use one and reassess the situation. And you can use the second one and reassess the situation. But if you are going for a third one, you need to rethink what you are doing and whether you need ICU management support with intubation, because you are nearly replacing the whole blood volume of a child. So now the other aim, you really need to, you are not going to get your blood pressure to the real normal level, upper limit of it. You keep the blood pressure about 50th centile for the age. You don't have to go and try to get the normal blood pressure. Child, I will explain it to you why we are not doing that in next few slides. So consider blood transfusion. That is why we were ready with the cannulation, grouping and DT, and then the blood is ready. So you can transfuse blood. You can use platelets as well as FFPs, but you need to get an idea from a transfusion specialist, and you have to have a OTM there so that you are guided, you are rationally guided by those tests as well as the transfusion specialists. So then once you do that, then you can use some octreotide as well as terlipressin. And then reassess the patient. Then you can again classify whether the patient is stable or unstable. So then we go to this section. So if the patient is stable, you can plan for varicose ligation within the next 24 hours. If the patient is still unstable, you can use gastric balloon pressure as well as esophageal balloon pressure. This is Esteban Blackmore tubes. There are so many other types of tubes that are being used at the moment. There are new variation of only esophageal pressure tubes. So you can use one of them and keep it there for a while, not more than 24 hours. Then you aspirate all the blood that comes up. And we have to be very careful because over-enthusiastic filling of the balloons can cause rupture of the esophagus, ulceration, and all that. After 24 hours, you have to reassess the situation. And if still patient is bleeding and unstable, there's no option other than going for surgery, which Vatsala will explain. If there is cirrhosis, you go for TIPS, transjugular intrahepatic polycystic shunting, where you shunt the hepatic vein to the portal vein to the hepatic vein, and extrahepatic portal venous obstruction you do. There are various types of shunting which you can discuss later. And if the fellow becomes stable, then you go for endoscopic varicose ligation. So this is the management plan for the child who is having acute varicose bleed. So this is like I was talking about. So they keep hemoglobin around 7 to 8 grams per deciliter, as over-enthusiastic transfusion could lead to secondary bleeds. When you give too much of blood, the varices will again refill and start bleeding again. So you need to correct vitamin K deficiency if there is a liver disease, and stabilization phase may need transfusion of, as I said, FFPs, platelet, and the blood product. You need to be guided with proton and transfusion specialists. Advice need to be sorted early if you are trying to give more than 2 blood transfusions, or if you think of all the other implications that happen. There is, if you see a huge large bleed, actually there is a protocol called massive transfusion protocol. You have to activate that immediately by calling transfusion specialists. So the monitor vitals regularly, correct blood glucose. If there is a necessity, keep it somewhere around 6-9 millimeters per liter. after adequate resuscitation. After adequate resuscitation, only you are going to correct acid base status if there is the base excess is less than -10. Right. Do not aim for normal blood pressure. As I said, keep it around 50 cm per day because it can also cause reflux. Do not shift unstable patient for endoscopy. Do not ask me to do endoscopy on unstable patients simply because we can't anesthetize these patients. It's going to be a real mess. So let's get them, as I always showed in the management plan, only stable patients goes for endoscopy. Remember that. So the long-term management, I will do part of this. So the best thing is to go for endoscopic and band, and then combine with pharmacological management on a regular basis and surgery for later stages when you're running out of options. So endoscopy two main types that we can do. So top one here we show in a small child where you can't band because the banding apparatus is sometimes can be larger. So in that situation, you go and do endoscopic sclerotherapy. We don't do this much at large. We do sometimes in a small children, right? Endoscopic variceal banding is something that we regularly do for children. So I'll show you one child whom this was a 4 months old child. Vatsala did this endoscopy. This is the youngest child. Don't worry about this blood. This is simply due to anesthetist problem. They stuck somewhere the endotracheal tube. So this we carefully intubate this child because he was 4 months. So that's the opening. Second. Sometimes very difficult in a small child. So, okay. Here we go. Can you carefully look here? You can see a varices from the upper one-third onwards, right? This child had a portal venous thrombosis, which is very acute. There are no collaterals, so all the pressures come back to the veins, and it develops severe large esophageal varices. You can see here. You can see a red spot here, which can lead to the next bleed. Can you see that, please? That one, and they are very dangerous. They can bleed at any given moment. So those are called red spots, right? So we go to the stomach. You will see more important things. You can see the congested stomach mucosa, gastric mucosa. You can see that because of acute problem. You can see watermelon appearance of gastric antrum here. And we go into the duodenum carefully and very skillfully move into the parts of the third part of the duodenum. And bile is there. Okay. So that's the duodenum. We come back. Okay. So there's nothing much there apart from mild condition of mucosa. We look very carefully for everything actually. So you just don't put the endoscope and take it back. Turn the first part of the duodenum again. Back in the stomach. Now we are going to look at the gastroesophageal junction, the reverse view, which called. So you can see there's a varix. There are two varices there, right? Those are fundal varices. You can see it here. Yeah, the one is very clear. The one is the other one. You see it coming from the esophagus. There are three actually. So those three varices that is formed because of the high pressure in the varices venous system. So we have to do something for that as well. So you can see the heart is beating. Very difficult procedure here in a 4-month-old child. So very clear here. You can see that. Right, so we are coming back. When you're coming back, you always watch very carefully about what you have to do next. Right? So which vein are we going to band and all that. we know what to do. It looks like a very large varices over there. So we are coming back. So then we decided to band this child. So these are the band. This is the banding device. This is the one we fix into the endoscope, and this is the shooting mechanism, right? So this is what there are 6 bands here, right? And then there's a different color one. When we finish this one, we know there's only one band left, right? There's only one band left, right? So let's see what we are doing here. So first, look at this, right? So first we have to fix the banding device into the lower end of the esophagus. That is exactly what we are doing. And fix, and then what we need to do next is to apply some gel. Okay. Here we go, gel, done. All ready to go now. So the 4-month-old child getting endoscopy again. Now this is very dangerous and very difficult sometimes because the end of the endoscope is enlarged because of this band set. Right, very carefully intubating this Vatsala's procedure. So she's intubating the child. That tiny space, we have to go through that very carefully. Damn. Now she goes in with some air into that. Now we look for the places. You can't start banding from here, right? Although you see something. It starts from the low end, right? So now you can very clearly see the red spot. This is the red spot that we are aiming at first. Then you suck into the apparatus, right? The varix is sucked into the apparatus and connected. So there's a little bit of bleeding. You can see very clearly that the varix is banded and the red spot is banded, right? So now you go for another place where you can go to the banding. Right, that's magic. See, very nicely it is done. And then you are going to try another one. Sometimes you are going to be successful, sometimes you are not actually. So here we go. So, look for a place. The one sucking in. You can see it is coming up slowly, but not. So there is a degree of bleeding here. So we think that is adequate. We applied the band, but it didn't go in, right? So this thing happened, right? So we failed in that band. So 3 bands gone now. Now there is bleeding. Now, if you are afraid of bleeding, you can't do the gastroenterology. You can't do anything actually as a doctor. So there will be bleeding. So you wash that off and try to find another place where you can band, right? Actually, you should band this time. So that is the previous very succinct. So we are not going to do that. So then you wash off the blood and be very sensible, careful. We know exactly how to stop bleeding again. If necessary, we can give some octreotide, but we really don't need it. So then you find another place. Let's see. Here we go. It comes and band. Banding. So now 4 bands are gone. Sometimes when you keep on banding, the varices tend to dissipate and disappear, right? So I want more if possible. So wash blood around. And wait a second, let's see whether we can find another one. So bleeding is there, or we just wash the blood. Sometimes you can't. So let's see. Everything possible and see whether they can get another one from somewhere on you. You have to get a clear vision before you band. That's why band that very seriously. Very nicely. Sure. So that is how we go. So that is the first part of management of long-term management. So we find varices and regularly band and try to abolish them as much as possible with the combination of medical management. So I will hand over the lecture to Vatsala to finish it off with pharmacotherapy and surgery.
Right. So as discussed, so the banding, I would say, plays a main role. But of course, evidence they have suggest that banding with pharmacotherapy has shown a much improving in the portal hypertension and disappearance of esophageal varices and reduction of variceal bleeding. So out of all the medications, I would say, because when we were medical students, we saw patients on ISMN, patients on propranolol. But now the drug of choice would be carvedilol, which is a non-selective beta blocker, as well as it has some alpha adrenergic blocking effect as well. So there are latest evidence, but I would say most of the evidence based on adult population. But however, that is in favor of carvedilol, which has a superior action. And when you compare the side effect profile compared to the other beta blockers we were using, so carvedilol has the, I would say, mainstay of treating esophageal varices or the portal hypertension even in children. So it has an extensive first pass metabolism, and so bioavailability would be 1/4 following oral administration, and it's bound to serum albumin. And basically, it is metabolized by the liver with some of the oxidation, glucuronidation, and conjugation. And the half-life would be around 7 to 10 hours. So usually we give it as a BD dose, one in the morning, one in the afternoon. So starting dose for children would be around 50 mics per kg. You can gradually increase up to 100 mics per kg. And the maximum dose would be 12.5 milligrams per day in children. So when we look at the pathophysiology, what happens in portal hypertension, so there can be several mechanisms we can discuss. One is increasing in hepatic vascular resistance with the structural factors as well as due to increased vascular tone due to this endothelial relaxing factors. And other thing would be the portal venous inflow. So carvedilol will act on these, so it can reduce the resistance. Basically, it decreases the hepatic resistance, which ultimately decreasing the portal pressures, as well as it can act on the splanchnic vasodilatation. So it will cause splanchnic vasoconstriction, causing reduced portal blood flow, ultimately causing reduction in the portal pressures. So that is the postulated theory behind carvedilol. So that's why the pharmacotherapy and banding should go in hand when you treat portal hypertension. A little bit about tips, which Sir just mentioned, but I would say even though this is a very common or very useful practice among adults, but I would say in children due to anatomical problems, we don't use it much in children. But of course, if there are children who is decompensating, waiting for a liver transplant, so just as a bypass surgery, sometimes people can do, where you connect the portal vein to the hepatic vein with the conduit. So this is what is happening in the transjugular intrahepatic portosystemic shunt, but which of course Dr. Miranthi will discuss later. So we don't use this in our children. I have not seen a child had a tips in my life. So coming back to surgeries, So surgery, the main idea behind doing a surgery is to reduce the, the backflow or the decompress the portal circulation. So for this decompensation, you can do either shunt surgery or a bypass surgery. So there are a number of names you can see here, depending on the site you want to bypass. So you will give a name. So it could be portocaval. So that is the connection between your portal system to your IVC. Could be mesocaval. That is a connection between your usually superior mesenteric vein to the IVC. Or could be the mesorex, which I'm going to discuss later, which is the commonest and most helpful shunt surgery in pediatrics. And sometimes you might kind of, bypass into renal vein to your splenic vein, could be into your portal system. So there are a number of surgeries which is a kind of practice which were used to kind of treat portal hypertension. But out of all, mesorex bypass shunt has become the most fascinating and most useful shunt out of all, as you can see, which is used in as a treatment for extrahepatic portal vein thrombosis. When you have a thrombosis, what they do is they kind of bypass this thrombus from with the conduit. So could be from the jugular vein or could be a long saphenous vein. So you get the conduit and bypassing from the superior mesenteric vein into the rex recess of your left portal vein. So this is one of the common surgeries which they use in the West. So out of all surgeries, I would say this is the most handy and useful bypass surgery for portal hypertension. So having said that, so we have come to the end of our talk. So we thought to discuss a little bit about our experience in treating children with portal hypertension. So as mentioned, we receive patients with pre-hepatic as well as hepatic portal hypertension. So we were successfully managing with regular banding as well as pharmacotherapy with carvedilol. And youngest child, you already saw what we did. So it was 4 months. She's still needing regular banding every 3 monthly, but doing very well. Now no more bleeds. And her spleen, when she presented to us, it was around 9 centimeters. Now it has shrunken. Now it's around 4 centimeters. And we had a few kids who were nearly adolescents with massive splenomegaly. So that may be due to the fibrosis of the spleen due to this portal congestion. So in good olden days, we used to tend to do splenectomy, but few of the children, with the help of Dr. Iranga Ganewatha, who's the interventional radiologist at LRH. So we tried splenic artery embolization in few of our children, which was a success. When we talk about hepatic portal hypertension, of course, they are doing fine without variceal bleeding, and of course, with the successful liver transplant program we have at Tragama, led by Dr. Meranti. So they are doing great without any problems. So a little bit about this splenic artery embolization. So we had 5 kids from 8 to 16 years who had total or partial splenic artery embolization. Only one had a complication with subphrenic abscess needing an abdominal drain in situ, but majority, all the 4 are doing fine. They are completely asymptomatic, other than mild pain in the abdomen and shoulder teeth. And we have continued the repeat endoscopy, and it showed a remarkable disappearance of varices. So even though in Western countries, they don't do splenic artery embolization due to the practical issues, but our experience is a little bit different. So we do see some success in doing this intervention in children with massive splenomegaly. So that comes to the end of our talk. So thank you very much for your patient listening.
Thank you very much, everybody, for the patient listening. Thank you, Veranti, for giving us the opportunity to do this lecture. Have a great, successful workshop ahead.